Good evening, everyone. My name is James Rue. I'm from the University of Illinois at Chicago, and I'm here to present the NACIT trial, specifically the second paper, the 50 to 69% paper titled Benefit of Carotid Endarterectomy in Patients with Symptomatic Moderate or Severe Stenosis. Before I begin, I just regret to let you know that my partner, Michael Bamamore, who we kind of discussed the paper together and we made the slides together, is unable to join us because of other responsibilities he has with his sub-internship. And I'd just like to thank the medical student, the training center, just for providing this opportunity to read and present this topic with you all. So diving right into it, in the early 50s, there was a Lancet article that published a case in which a patient with stroke-related symptoms was treated with the removal of the stenosed segment of the carotid artery. Ever since that paper, between 1974 and 1985, about 1 million carotid endarterectomy procedures were performed worldwide. And during this time, the increasing rates of complications and multiple retrospective database reviews kind of led to question the efficacy and the benefit, whether it's worth the risk, the perioperative risk to perform carotid endarterectomies in all these patients. So they really understood that there was a need for a large randomized controlled trial. And that's what led to the first trial that we're familiar with, that being NACIT. So what this trial did was they studied carotid endarterectomy in patients with three different groups, one being the low moderate risk group who had under 50% stenosis on angiograph, and a high moderate group, which would be 50 to 69% stenosis, and a severe group, which was 70 to 99% stenosis on angiography. So the main questions they wished to answer with this trial was, how efficacious was CEA compared to medical therapy alone? And if it was indeed efficacious, which patients should be offered CEA, what the acceptable complication rate was, and what risk factors might have an influence on the benefits of CEA, and how durable those benefits might be. And also if there were any other causes of stroke that would confound the interpretation of these results. So the first arm, that being the over 70%, 70 to 99% stenosis group, the first arm of the trial was terminated a little earlier because they had some quite significant results. So I'll just summarize those results before I move on to the other paper that we had reviewed. 662 patients were with carotid stenosis of over 70% occlusion were randomized in this arm. 331 patients were treated medically, 328 were treated with surgery, and 3 were excluded from the final analysis. And what they saw through this trial, what this paper demonstrated, was that the cumulative risk of any stroke at 2 years was 26% for those who were treated medically and 9% for those who were treated with carotid endarterectomy, amassing up to a 17% absolute risk reduction, showing that carotid endarterectomies were very efficacious in decreasing the risk of stroke at 2 years for these patients. Also, major or fatal ipsilateral strokes were also reduced by 10.6 points, and so were any major stroke and all-cause mortality in this trial arm. So after they published that paper in 1991, and then they terminated that arm. They continued to enroll patients in their moderate and low risk groups. So I'm going to be talking about that second paper that they had published later on with those, just analyzing those two groups. These are some of the inclusion and exclusion criteria for enrollment of those patients. So patients with symptoms of focal cerebral ischemia, ipsilateral to IC stenosis under 7% shown on angiography within 180 days of symptom were included. And then there are also a variety of exclusion factors that they had used to exclude patients, shown on the right here. So what they did was they used angiograms to stratify patients to a low moderate stenosis group and a high moderate stenosis group. And then they randomized patients into two treatment arms, one being medical therapy and one being carotid endarterectomy. They followed up with a neurological assessment at entry and 1, 3, 6, 9, 12 months, and every 4 months after that. They did cross-sectional brain imaging after any suspected event, that being any suspected stroke or any neurological deficit was noted. Duplex ultrasonography was performed at 1 month and every 1 year after, and after every suspected event as well. The primary outcome event that was used in this study was fatal or non-fatal stroke, which was ipsilateral to the original site of stenosis. They mainly performed these analyses, one being the intention to treat analyses, comparing the medical and surgical patients in terms of time to treatment failure using these statistical methods. They also did a logistics regression analysis to look for risk factors for stroke 30 days post-op after surgery. They also looked at the influence of risk factors in determining which patients benefited from carotid endarterectomy through a Cox proportional hazard regression model. So going right into the results, a total of 2,226 patients were enrolled. There were 1,118 patients in the medical group, 1,108 patients in the surgical group, and I think 41 patients were excluded. And again, they were stratified according to the degree of stenosis, and they were followed up to about 5 years during this trial. So regarding the high moderate to low moderate risk stenosis groups, we can see that for patients with a 50 to 69% stenosis, they saw a moderate benefit in for surgical therapy. The risk of ipsilateral stroke in the medical therapy was 22.2%, while the risk for any ipsilateral stroke in the surgical group was 15.7%, and that totaled up to about a 6.5 absolute risk reduction. However, in the low risk group, that being the stenosis under 50% group, there was the p-value was pretty high, and there was no any benefits seen from performing a surgical therapy over medical therapy. And these are, I believe, time to treatment curves. I'm sorry, time to event curves in which they saw a statistically significant difference of any ipsilateral stroke in the prior arm, followed up to 8 years. What's interesting is that in the 50% to 69% stenosis group, we can see that benefit of reducing events, ipsilateral stroke events, is very diminished. And contrasting to the 70 to 99% stenosis arm, we can see that in these two curves, we can see that the confidence intervals overlap somewhat, and that the p-values are actually very marginally lower than 0.5. For any ipsilateral stroke in under 50% stenosis group, we can see that there was no significant difference between medically treated and surgically treated arms. So this is another graph depicting the risk of stroke during the follow-up of 6 years. We can see that the benefit of surgical therapy really resided in those first 2 years after treatment. You can see in both the 50 to 69% stenosis arm and the 70 to 99% stenosis arm. The main difference between the medical therapy and surgical therapy groups in terms of risk of stroke is really apparent up to those first 2 or 3 years. and then after that, it kind of levels out. So we thought that was pretty interesting to see. In the third figure here, these are Kaplan-Meier curves for time to events, in which this is just kind of like a follow-up study of those patients that were treated with carotid endarterectomy in the 70% stenosis group. And you can see that it has somewhat, the surgery had somewhat of a durable effect, especially in preventing disabling ipsilateral stroke, up to 5 and up to even 8 years. So of course, all studies are without, there are no studies without limitations. So they had highlighted some limitations that were particularly important to think of when extrapolating these findings to the general population when, in terms of treatment. First of all, the authors of the study had noted that they used a high level of expertise of participating surgeons to perform this procedure. And then secondly, they had a consistent measurement method, that being the angiography, to kind of calculate the degree of stenosis. And I think we kind of talked about it last week, in which the NACIT trials used a calculation method in which they will calculate the difference between the portion of the stenosed, the narrowest portion of the stenosed segment, and the ICA, the distance of the ICA, the diameter of the ICA, the diameter of the ICA distal to that segment, and then kind of divide that by the diameter of the ICA distal to the stenosed segment. And they brought this up because not all institutions can perform angiograms, I think, and especially in patients who were identified of having carotid stenosis through kind of imaging such as duplex ultrasonography. I think they wanted to highlight that there may be differences, and angiography should be the gold standard imaging used to kind of determine the degree of stenosis. One other limitation that they had posited was the consideration of clinical and patient-specific risk factors when weighing perioperative risk and long-term benefit. Another section of the paper that we had failed to include in making these initial slides was they had performed a univariate analysis of baseline characteristics of perioperative stroke risk. And they found that certain factors kind of contributed to elevating that stroke risk after CEA. And they also showed a Cox regression to determine which patients would have a long-term benefit with carotid endarterectomy. And I think they really urged providers to weigh those risks and benefits by case to case, especially in this the population that they studied in this paper. So to summarize these trials, patients with 70% to 99% stenosis obtained a durable benefit from carotid endarterectomy over medical management. However, patients with 50% to 69% stenosis obtained somewhat of a marginal benefit from carotid endarterectomy that was most seen in the first 2 or 3 years compared to medical management. And patient-specific risks and benefits in this group should be thoroughly evaluated on an individual basis before deciding modality of treatment. Patients with under 50% stenosis has not shown to benefit from carotid endarterectomy over medical management. And this is the paper that we had reviewed. So thank you, and I'd be happy to accept any comments or questions.
Really excellent review. Should we move to the next 2 articles and we can discuss all of them at the end and take questions?
Yeah, sure. Do I need to stop sharing before somebody else can jump on, or?
Yeah, James, you should stop sharing now, and then David will go.
All right. Thank you very much.
Okay. Good evening, everybody. Can you A, hear me, and then B, see my slideshow?
Looks great.
Okay, thank you. So hello, everybody. My name is David Botros. I'm a third-year medical student at Johns Hopkins University, and I have the pleasure of following James's talk, which presented a really sentinel study that kind of preceded this one, as well as talking about this specific study. So as you can tell by the title here, this paper was titled the Endarterectomy for Asymptomatic Carotid Artery Stenosis. So the focus here was being able to intervene prior to us having any sort of any symptoms that we can see. So this comes from a background of strokes being recognized as an entity that causes a large disease burden. And at the time of the study, the stroke rates were pretty remarkable, 500,000 annually. And now it's even more so. So a 2020 study in Circulation showed that it's up to 795,000. And I think part of the reason for the study is that strokes are insidious and some are disabling at onset and don't really have the things that we would see prior, like TIAs or any sort of notable symptomology. And they posited in the study that carotid artery disease is responsible or may be responsible for about 20 to 30% of these strokes. While on the other hand, the procedure, the carotid endarterectomy, carries a fairly reasonable 30-day morbidity and mortality risk. They ranged between 0 and 3.8 for asymptomatic folks, which are the subject of the study, and up to 6% for symptomatic patients. And so that kind of drove the initiation of this current study. And just as a quick breakdown of the procedure itself, this is a quite simplified infographic, but it tells all that we kind of need to know, and that it's a local surgical intervention that we identify the involved vessel, the carotid artery, and then take out the plaque that's there. There's usually or possibly shunting involved if it'll be a prolonged procedure. And some of these complications here can be very detrimental to patients. And so that was another consideration here as well. So the main question is that will this procedure, along with aggressive reduction of modifiable risk factors, which is something that we'll talk about later, as well as aspirin, reduce the 5-year risk of ipsilateral cerebral infarction in individuals with asymptomatic hemodynamically significant carotid artery stenosis? And so that's quite a large question, but basically, does this procedure help? And so to study this question, they recruited a number of patients from nearly 40 centers with more than 30 patients each. I think at the end, it was an average about 42 patients per center. They recruited from ultrasound vascular labs, from practitioners who noted carotid bruits on exam, and then any carotid stenosis that discovered while evaluating for other procedures, or contralateral, or in the process of contralateral CEA. And so the inclusion criteria was patients between 40 and 79, a compatible history and physical and a neuro exam, and fairly recent labs and ECG exams, things that you would consider for surgery, and then obviously informed consent and willingness to undergo follow-up for 5 years, which is quite a long time and actually presents a difficult part of this study. So their main exclusion criteria were as follows: if they had cerebrovascular events in the study artery that they determined was stenosed, any other cerebrovascular events in the vertebrobasilar system, which you kind of have a small image of on the right, or a fairly simple one, any contraindications to taking aspirin, and then contraindications to surgery. And the reason I put an asterisk next to this is because it's quite a vague contraindication or issue to raise, especially when trying to generalize this to today, when we have a lot of ways of pre-optimizing patients to get them to surgery. But contraindications to surgery was an exclusion from this study. And then having contralateral hemisphere symptoms within the previous 45 days, and then conditions or comorbidities that would limit their goal of follow-up for 5 years. And so as James really was getting into how they determined degree of stenosis, they had a few definitions. So if they'd had an arteriogram that showed 60% stenosis, the calculation of which we'll have in the next slide, or a Doppler ultrasound with pre-specified cut points. I don't think the exact definition matters per se, rather than establishing the carotid artery was stenosed with the cut points at the time. Ultimately, all patients that were randomized to the surgical arm actually got an arteriogram or had arteriography. And so at least that in the surgical arm, that was addressed. So really quickly, just to talk about how they determine the degree of carotid artery stenosis. So this portion right here would be determined the minimal residual lumen. And so this is the same definition that they use in the NASCA trial. This would be the minimal residual lumen. This would be the distal lumen, and they have 1 minus minimal residual over distal lumen to give you the degree of stenosis. And the use of this, the consistent use of this definition actually really helps with studies that came after. As you can see, there are some other definitions that came from other studies. So the study design and analysis, patients were randomized to medical treatment with 325 milligrams of aspirin, plus stroke risk factor modification with their practitioners, with their general practitioners, which is, again, quite a vague part of the medical treatment. And then surgical treatment, which is the above plus the procedure. It was non-blinded as they had a procedure. And then the enrollment went from 1987 to 1994. 1987 to 1994. They screened over 42,000 patients, but ultimately included just a little over 1,600. And similar to the NASCA trial, they used Kaplan-Meier estimates of 5-year aggregate risk, and also used intention to treat analysis. So their initial primary outcome at the design of the study was all of the ones that you see here, plus the TIA and the distribution of the study artery. They ultimately modified it in 1993 after a few studies came out showing that the incidence of TIAs or TIAs themselves, they weren't really sure what to make of the results from those studies and how they were maybe not so significant for survival. And so they ultimately decided not to include them. And so cerebral infarction and the distribution of the study artery, any stroke or any death occurring in the perioperative period were their primary outcomes. And then they had a number of secondary ones that were basically composites, different combinations of these outcomes. So some demographics here. The study population was majority male and white or Caucasian, which is something that we'll discuss kind of at the very end with limitations. Risk factors were similar among the two arms, so it reflects the randomization that they saw. And then median follow-up here was 2.7 years. Only 9% of the patients that they had completed 5-year follow-up. Mean age was 67 years, and as you always have with a randomized clinical trial, there will be a crossover. So 45 patients in this case, which is actually a pretty decent number, went from initially being in the medical arm to eventually getting CEA. And so in an intention to treat analysis, they would remain in the medical arm, which would affect the randomization a little bit, or the results, sorry. So now to discuss the outcomes, in their primary outcome, the ipsilateral stroke or any perioperative stroke or death, they did find that carotid endarterectomy had a 53% reduction. So right here, 53% reduction in risk. And this was a statistically significant finding, along with ipsilateral TIA or stroke, or any perioperative TIA or stroke or death. We'll discuss, I think, a little bit of the limitations about how combining all of these outcomes together may take away from the statistical rigor of a study, but we'll kind of keep talking about the outcomes as well. So the estimated 5-year risk of ipsilateral stroke, this outcome that we saw a little while ago, was 11% in the medical group and 5.1% in the surgical group, which reflects this 53% reduction. And these are the survival curves, or the time to event curves that were associated with both of those. So we see here, this is the first finding, the major one that they report in the study, and then the second one. Again, I'm just highlighting these here. And the secondary outcomes, I think it is also important to note. So this is medical group compared to surgical group. Sorry that I didn't delineate those. It is important to note that while the p-values do not cross the 0.05 threshold, there is definitely a trend that the medical group was experiencing these events at a higher rate. The trend is there. Could be a power issue. They did do a power analysis beforehand, but these are the results. They did some subgroup analyses as well to compare, to stratify by male versus female. Again, if we go back to the study design, they had majority male population, which kind of affects their ability to analyze the female population on its own. And so they actually, this result, their primary outcome, was not significant in their female group, but was in the male group, and then it was in the larger overall group. This is something I think that we'll also discuss in the limitations. So finally getting there, the conclusion is that in properly selected patients, again, keeping in mind their stringent exclusive criteria or exclusion criteria, that in properly selected patients with greater than or equal to 60% stenosis, CEA demonstrated a 53% reduction in ipsilateral stroke risk. Again, the limitations that I kind of discussed along the way, the study definitely lacked large data on females and other race groups. We sort of know that cardiovascular disease disproportionately affects other race groups like African Americans, for example. And in this study, they only represented 3% of the population, the study population. So, which is not reflective of their makeup of the US population. Their primary outcome included multiple different endpoints. And so these are composite endpoints, which presents an issue because then you really can't delineate which one is driving the statistical difference. And then the main thing here is also that medical therapy at the time for risk factor reduction was definitely different than what we use today. Statins, for example, had only been around for roughly so they were in 1985 was kind of the start of statins, and the study concluded in 1995 or was written in 1995. So definitely wasn't as popular as they are today. And there are new medications all the time, like currently SGLT2 inhibitors are coming on. So there's definitely a lot of ways for us to mitigate cardiovascular risk and stroke risk that were not tested in this study. And then the extremely limited follow-up, which, again, they only got to 2.7 years of follow-up rather than the 5-year goal. And with that, I'm concluding my study or concluding my presentation.
All right, so my name is Lauro Nathaniel Avalos. You can call me just Lauro. I'm at UCSF. And today I will be presenting stenting versus endarterectomy for treatment of carotid artery stenosis. This was a study published in 2010. It's otherwise known as the Crest trial. So the questions asked for the study are what are the relative efficacies and safety profiles of carotid endarterectomy and carotid artery stenting for carotid stenosis in a heterogeneous population, meaning both symptomatic and asymptomatic. So the study design, it was a randomized, multi-center, unblinded control trial with blinded endpoint education and intent to treat analysis. So the number of patients enrolled was 2,502 between 2000 and 2008. At 117 centers, 108 in the US and 9 in Canada. The clinical teams were comprised of a neurologist, an interventionist, a surgeon, and a research coordinator. The surgeons and interventionists had to show proficiency in their procedures, so they had to complete a number of procedures, whether it was endarterectomy or stenting. And then once they were certified and deemed proficient, they were allowed to participate as either interventionists or surgeons in this study. So, and just to check one more time, you can see me changing, right? I'm on population.
Yeah, we can see population.
Great. All right, so for the inclusion criteria, the patients had to have symptomatic carotid stenosis, and this was defined by transient ischemic attacks or episodes of TIAs, amaurosis fugax, or minor non-disabling stroke involving the carotid artery that was to be studied within 180 days of randomization. And then you could also have asymptomatic carotid stenosis. And then, of course, you had to have an internal carotid artery that was involved, and it didn't matter if the common carotid portion of that vessel was included, or stenosis as well. So these are the eligibility criteria for the degree of stenosis. So in this red rectangle is for symptomatic patients. So stenosis was, if stenosis was done through, or a measurement of stenosis of the vessel was done through angiography, had to be within 1 year of randomization, and the NASIC criteria had to be used for stenosis. So the artery had to be stenosed greater than or equal to 50%, and then if ultrasound is used in a Crest certified lab, it had to be greater than or equal to 70%. But if that stenosis was in between 50 and 69%, then a CT and MRA was used. And that cutoff was also greater than or equal to 70% for stenosis in the symptomatic group. And then the asymptomatic group had slightly higher indications of stenosis for treatment. So for angiography, it had to be greater than or equal to 60%. And then the same for ultrasound criteria of greater than or equal to 70% stenosis. And then again, if in between 50 and 69%, a CT MRA was done, and the cutoff criteria was greater than or equal to 80% stenosis. So for the exclusion criteria, the patients were excluded if they had chronic AFib or paroxysmal AFib lasting less than 6 months, or within the 6 months of the randomization, or medically treated AFib, and then ACS in the past 30 days. And then there was a large number of clinical and anatomic suitability criteria for the patients. For the clinical exclusion criteria, there's over 21. Most notable is really just anything that affected the endpoint. And the endpoint we'll get to in a little bit, but that will confound those data. So a lot of comorbidities, such as like evolving stroke, already mentioned chronic AFib, dementia, because a lot of some of the endpoints, especially for stroke or TIA, it was done through surveys and self-report. And the anatomic exclusion, same thing, anything that would prohibit a stent from going in and collapsing the plaque and the stenosis appropriately. So again, severe vascular tortuosity, and then there was really only 7, so you can read these here. Now for the methods, there was 2 treatment arms, so carotid artery stenting versus endarterectomy. So for the stenting, the RX Acculink stent plus RX Accunet embolic protection device was used. The patients were also managed medically pre and post-operatively. For the endarterectomy group, they received a standard endarterectomy procedure that is described elsewhere. Pre and post-op medical management as well. Now, the primary endpoints for this was a combined endpoint, so it included stroke, MI, or death from any cause during the peri-procedural period, which is defined, I think it was in 30 days after the procedure, and there was another criteria that I'll have to find, and then they did sort of a longitudinal study as well in this, so any ipsilateral stroke within 4 years after randomization. Here's the equipment, so the stent that they used, and then this is the embolic protection system that they also inserted. Now for the results, there's 2,522 patients underwent randomization. 1,271 were assigned to stenting group, and then 1,251 were assigned to the endarterectomy. All in all, 1,144 underwent assigned intervention. For the stenting, 1,194 underwent assigned intervention for the endarterectomy. As was mentioned earlier, there's going to be a number of crossovers or people that drop out or have just declined the treatment, and this is a very busy table, so here are all those points. So 1,262 for the stenting group had data included in the analysis, and 1,240 had data included analysis for endarterectomy. And these are some of the people that dropped off for various reasons. And this is the relative proportions, or this relative numbers of patients in either treatment arm for each age range. There was, in any analysis, there was no significant difference between the groups in the respective age ranges as well. Okay, so for the baseline characteristics, for the age and other demographics such as race, sex, there really wasn't any significant differences between the groups. So carotid endarterectomy stenting group was here on the left. The carotid artery stenting on the left and carotid endarterectomy is on the right. So for risk factors, there was a significant difference with for dyslipidemia, with the carotid endarterectomy group having 85.8 and 82.9 for carotid, the stenting group. Otherwise, they were pretty similar in blood pressures, and then one of the most significant things for this was that there was really no difference in moderate nor severe stenosis between the two groups. And then there's no comparative analysis here. There's really just a descriptive chart of the different procedural characteristics for stenting here, such as the certain medications used and the lesion length, and then endarterectomy down here, and the procedural characteristics. Okay, so now this is table 2, which is a table on the primary endpoint, and also the endpoints divided into very specific events. So at the top here, we have the carotid artery stenting group, and you're gonna have number of patients plus percent of patients plus standard error, and then the endarterectomy on the right, the absolute treatment effect, the hazard ratio, which I really pay attention to, and the p-value for comparison between the stenting group and endarterectomy. And the hazard ratio will include the confidence interval. So for death, there wasn't a significant difference between the groups in terms of how many people died. So 9 or 0.7% in the stenting group and 0.3% with a p-value of 0.8. Now for stroke, there was a significant difference with the stenting group experiencing more strokes with the p-value of 0.01, and then more specifically, what was really experienced in significance was the minor ipsilateral strokes. For the stenting group, it was 2.9% versus 1.4% with a p-value of 0.009 and it has a ratio of 2.16. And then this is this is another metric for the strokes, but what they did is they just combined the types of major. So ipsilateral or non-ipsilateral. So it's going to be here major stroke and minor stroke. And then so for minor stroke, that was the one that was only significant between stenting and endarterectomy is 2.2% versus 1.7 in the endarterectomy with the p-value 0.09. And then for myocardial infarction, the endarterectomy group experienced a significantly higher rate of MI, so with a p-value 0.03 compared to stenting, which was 1.1%, and it has a ratio of 0.5. So this is just a combined endpoint for just stroke and death. And again, combining those, there was a significant difference between the stenting, which experienced 4.4% for both versus 2.3 with a p-value of 0.005. But then when you combined all three major individual endpoints into the main primary endpoint, that significance balances out between with the stenting experiencing more strokes and the endarterectomy experiencing more MIs to make it not a significant difference. So overall 5.2% of patients experienced events in stenting versus 4.5. So again, no significant difference.
So I just want to summarize the three papers. So the first one we talk about is really the NASAT study, and this is perhaps the most important paper to discuss tonight. You know, the original paper, as James pointed out, was 991 in England Journal of Medicine, which really showed that in patients with 70% and above stenosis in symptomatic patients, endarterectomy is significantly better than medical therapy, which was aspirin at the time, with a absolute risk reduction of 17% at 2 years. So these are numbers worth remembering. Again, they'll ask you this, I think, on your STEP exams and perhaps on your written boards also. So 26% to 9% 2-year stroke difference between surgical group and the medical treatment group. And also, as pointed out, once you go below the 70%, so the moderate group, 59%, the benefit is much more marginal. So I think the take-home message here is that if you have symptoms, basically minor strokes or TIA, and the carotid artery is 70% or above narrowing, surgery truly or stenting is indicated with a high kind of risk, high benefit to risk ratio. And once you go to the moderate group for 50 to 69%, the benefit is much more marginal. Really, it's only about 1% risk reduction per year. And also to note that at the same time of the first NASA study, there are also 2 other randomized trials, the ECST and the VA study. There are also very famous studies that really essentially show the same thing. And these 3 studies together basically form the cornerstone of using carotid endarterectomy as a treatment for patients with symptomatic carotid artery stenosis of 70% and above. So this kind of basically shows that, presents data in a different way. So here it basically says that you just need to treat 7 patients, you know, with carotid endarterectomy to prevent one stroke, non-disabling stroke or TIA. So again, a very powerful treatment modality in the symptomatic patients. So the second study presented by David was the ACAS study. So this study is a different study in the sense that it looks at patients who are asymptomatic with no TIAs or strokes. So in this study, as pointed out, the risk reduction is much more modest. It's almost akin to the moderate group in the NASA study. So 11% to 5% over a course of 5 years. So again, roughly 1% per year risk reduction. And of course, all the surgeons in these studies, they're experts with a very low complication rate. So in ACAS, the complication rate was 3%, which really means that you can only get this benefit of 1% per year stroke reduction if you have complication rate of 3%, which is quite low. So that's less than 1 in 20 cases of having a problem. So in other words, the benefit is probably modest at best. And also another thing to remember is that back then you're comparing would it be an ACID or ACAS? You're comparing surgery against aspirin. And medical therapy, of course, now with statin, with the new antihypertensives, with kind of dietary control, exercise, lifestyle modification. The medical therapy arm have made significant progress in the past 25 years since these studies have been published. So now there's an ongoing study called Crest 2, which is looking at carotid endarterectomy or stenting versus medical therapy, and the results are the trial's still ongoing, and we probably won't have the result for the next five plus years, but something to keep an eye on. Finally, Crest. Laura is kind of finishing it up on Crest. The take-home point is that it's a large study. Unlike NASAID and ACAS, it looks at a mixed bags of symptomatic and asymptomatic patients. So remember, NASAID was only for symptomatic patients and ACAS only for asymptomatic patients, whereas Crest is a mix of the two. But nevertheless, a fairly large study. And the primary endpoint, rather than just looking at stroke and death, like in ACAS and NASAID, also included MI in the study as a primary endpoint. The bottom line is that the two modalities in this mixed group of patients are essentially identical, showing that both therapy are efficacious and safe. But if you really break down into finer details, you notice that minor strokes are more common with carotid artery stenting, whereas MI is a little bit more common with surgery. And these numbers are significant. So in general, what I tell patients is that overall, in both symptomatic and asymptomatic patients, stenting and endart are fairly similar, with endarterectomy having a slightly higher risk of MI, and stenting has slightly higher risk of minor strokes. Now, one other study that I think is worth mentioning is you guys see here is called a Sapphire study. This is really the first study that has kind of established stenting as a reasonable alternative, and is actually behind the reasons why CMS reimburses stenting. So this study published in New England Medicine in 2004 basically shows that stenting is not inferior to surgery in high-risk patients. And again, they look at both symptomatic and asymptomatic patients. And these are probably criteria that's worth remembering for high-risk criteria for surgery. So basically, significant medical comorbidity like heart disease with heart failure, low EF, unstable angina, and recent MIs, severe pulmonary disease, elderly age, recurrent stenosis, contralateral occlusion, prior neck surgery radiation, contralateral laryngeal nerve palsy, and high bifurcation. So these are basically high-risk criteria for surgery. You can kind of group them into kind of medical reasons, like like comorbidities, like sick heart and sick lungs. Anatomic reasons, like the bifurcation is high, hard to reach for surgery. Prior neck dissection making surgery more difficult, or other reasons such as contralateral occlusion, and the contralateral laryngeal nerve palsy, etc. So I'll stop here. This is just a quick summary of all the 3 studies that are discussed, and in the last few minutes, we'll be happy to take any questions or listen to any comments or ideas you guys might have. Thank you very much.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.